uvula without tip, soft palate and hard palate are seen. Whereas when it comes to class 3, what happens? Pillars you won't see, fauces you won't see, uvula only base is seen, soft palate is seen, hard palate is seen. Whereas when it comes to 4, pillars, fauces, uvula, soft palate does not seen, only hard palate is seen. So among this, visualization of soft palate and hard palate only are seen in. So the closest answer in this is uvula with only base. So it will be class 3. Okay. So see this is the modified Mallampati grading, where in 1 you see pillars, fauces, entire uvula, soft palate and hard palate. In 2, uvula except the tip. In 3, only uvula with the base. In 4th, you won't see anything. So this is what grade 1. You see pillars, fauces, uvula is entirely seen, soft palate, hard palate. Grade 2, you don't see the pillars, but fauces is seen, tip not seen, soft palate and hard palate. In grade 3, only base is seen, soft palate and hard palate is seen. In 4, only hard palate is seen. So 1 and 2 are easy intubation. 3 and 4 are difficult intubation. 3 and 4 are difficult intubation. Clear? Then Aldred scale is used in stages of anesthesia, discharge criteria, pain rating, neuromuscular monitoring. I told you like very easily you can remember. So this is very good. Discharge criteria. What is the another scoring system used for daycare surgeries? To discharge, what is fantastic, good Sinam. It is another scoring system is PADS. Post-anesthesia discharge scoring system. Post-anesthesia discharge scoring system. A patient getting admitted, operated, and discharged on the same day is called as daycare surgeries. So in this, we have 2 scales which we use. So a patient shifting from PYQ or post-anesthesia recovery room to ward, we use Aldred score. Whereas to shift the patient from ward to home, we use PADS. So what are the common things? Both has maximum score of 10, and the minimum score required to discharge is they should achieve 9 out of 10 should be attained to discharge. See here, what are the components? And modified Aldred score. Activity, whether this patient is moving all the extremities voluntarily on command, whether it is moving only 2 extremities or unable to move. Respiration, able to breathe deeply and cough freely, or any dyspnea is there, 1 point, apneic, 0 points. If blood pressure within 20% of the range, 2 points, 20 to 49% of the range, 1 point. If it is fluctuating more than 50% of the pre-anesthetic level, then 0. If the patient is fully awake, 2 points, arousable and calling, 1, not at all responding, 0. Oxygenation, on room air more than 92%, 2. Needs oxygen to maintain saturation more than 90%, 1. Even with oxygen less than 90%, 0. No need to by heart this. This is just for your understanding. They won't go in deep about what are the components. So there will be 5 components. Maximum score is 10, minimum score is 0. At least the score required to discharge is 9 out of 10. Please remember. The another thing is PADS, post-anesthesia discharge scoring system. The next question. All of the following are reversible causes of cardiac arrest management except. Come on guys, answer. Very, very, very important question which keeps repeating. Hypoxia, hyponatremia, tension pneumothorax, acidosis. Fantastic. Hypoxia is the correct option. Tension pneumothorax is the correct option. Acidosis, H+ion is the correct option. Hyponatremia is the odd man out here. Hypokalemia or hyperkalemia are correct answers. So whenever you see the reversible cause of cardiac arrest, 5H and 5T should be there. You have to remember and do that. One of the potential questions, not only for MRB, but also for the NEET-PG and INACT examinations. So what are 5H and 5T? 5H, hypoxia, hypovolemia, hypothermia, hypokalemia or hyperkalemia, H+ion, that is acidosis. Then what are 5T? Toxins, tension pneumothorax, cardiac tamponade, coronary thrombosis and pulmonary thrombosis. This should be in your tips at any point. Like one question, no matter what, will appear regarding the AHA CPR guidelines are related to the CPR, because it is one of the most fundamental thing which a doctor at that level should be knowing it. Okay. The next question. American Society of Anesthesiologists classification of a patient with severe systemic disease that results in functional limitation. ASA 3, 1, 2, 4. Fantastic. The answer is ASA 3. This is, you have to remember the definitions of ASA physical status classification formulated by Mayer Sackland, and also you should be remembering few of the examples. So here, ASA physical status classification. ASA 1 is a normal healthy person, no smoker, no or minimal alcohol usage. ASA 2 is a patient with a mild systemic disease with no functional limitation. So the examples are current smoker, social alcoholic, patient of pregnancy, obesity with BMI between 30 to 40, well-controlled diabetes, hypertension, and mild lung disease. What is 3? A patient with a severe systemic disease. Understand? Severe systemic disease with some functional limitation. See the difference here. 4 is also a patient with severe systemic disease. Then what is the difference? Here, a patient with severe systemic disease with constant threat to life. We mentioned constant threat to life, it is 4. With some functional limitation is 3. No functional limitation is 2. So what are the examples under ASA 3? Alcohol dependence or abuse, morbid obesity with BMI more than 40, poorly controlled diabetes or hypertension, implanted pacemaker, if ejection fraction is moderately reduced, and any patient and end-stage renal disease patient on regular dialysis, and any patient who underwent with a history of MICVA, stent insertion, transient ischemic attack, CAD, with more than 3 months history, it belongs to 3, whereas less than 3 months, that is a recent, belongs to 4. So similarly, end-stage renal disease on regular dialysis belongs to 3, whereas an irregular dialysis or acute kidney disease belongs to 4. Moderate reduction of ejection fraction is 3. Severe reduction of ejection fraction is 4. So, and also sepsis and disseminated intravascular coagulation belongs to 4. Okay. Then when it comes to 5, a moribund patient who is not expected to survive without surgery. So if you take the patient into the operation theater, the patient is so sick, if you take him to the operation theater, there are 50-50 chances. He may survive or he may succumb. But if you won't treat him, if you won't operate on him, he will die for sure, 100%. So what are the examples? Ruptured abdominal or thoracic aortic aneurysm, intracranial bleed with a mass effect. No matter what, you give liters and liters of mannitol, you have to go for emergency decompressive hemicraniotomy and do that. Then similarly, in case of massive trauma, ischemic bowel, in addition to cardiac pathology, multi-organ dysfunction syndrome, all these things you have to remember. Then 6th is a declared brain dead person, posted for organ retrieval and donation. So potentially we are expecting from ASA 6, the question may be there. And if any, after this ASA 1, 2, 3, anything, if E is added, that indicates it's an emergency surgery. Please remember that suffix. So ASA physical status classification, you should be on your tips on any particular day, guys. Then another important topic, twice a question was asked both in 23 and 25, increase in ETCO2. Capnography is again another important topic. Increase in ETCO2 is seen in all except hypothermia, hypothyroidism, sepsis, shivering. So don't see, most of you know the answer, but only thing is you jumped and marked with few of your hypothermia, because when you see increase in ETCO2, that excitement, yes, I know about this. But only thing is, if you go back and see, almost 40% of the questions they're asking except. So please read the question carefully, guys. Okay, please. So increase in ETCO2 is seen in all, like hyperthermia, yes, it will be increase will be there. Sepsis, shivering, it will be increased. Hypothyroidism, there will be decrease in the ETCO2. This is the correct answer. So roughly how you can remember, ETCO2 increase is seen in any condition where there will be increase in metabolism or hypoventilation. There ETCO2 will increase. Where do ETCO2 decrease? Wherever the metabolism decreases and in conditions of hyperventilation. That's as simple as that. Now they can give 100 examples, 100 scenarios. You can, by just remembering this, you can answer. Let's few of the things. increase in EtCO2. Increased metabolic rate. In all these conditions, there will be increased EtCO2. Fever, sepsis, seizures, malignant hypothermia, thyrotoxicosis, increased cardiac output, all these things. Whereas other way around, hypothermia, pulmonary hypoperfusion, cardiac arrest, pulmonary embolism, hemorrhage, hypotension, all these things will decrease. So roughly remember, anywhere metabolism increase, EtCO2 increase. If there is hypoventilation is there, EtCO2 increase. Other way around, whenever metabolism decrease, EtCO2 decrease, hyperventilation is there, EtCO2 decrease. That's it. Okay, then sudden increase in EtCO2 is seen in all of the conditions except malignant hypothermia, thyroid storm, pulmonary embolism, rebreathing. Choose the best option. Fantastic. Malignant hypothermia, rapid increase. It may go up to more than 100 also. Thyroid storm, because there will be sudden release of spurge. So you also see the rapid increase here, but not as much as malignant hypothermia. Then pulmonary embolism is a characteristic of rapid decrease. And rebreathing, what happens? It won't touch the baseline and it will increase. So it will be like this. It won't touch the baseline. So it will be, here also you'll see the increase. Now, among the options, technically speaking, you can think, okay, why can't it be the 4? Because it not be the sudden increase won't be there. But again, you have to choose the best option. The best option here is pulmonary embolism. Please try to understand how carefully you have to pick the answer. So you can technically argue why can't it be rebreathing? You mentioned in the question sudden increase. In rebreathing, there will be slight slow increase only will be there. It won't be so phenomenal. But there's a outright option is there where pulmonary embolism. So you have to go ahead and mark that. Okay. So am I audible and clear? Or is there a lag? Okay, but my screen, okay, fine, good. So this is what the answer is. Okay, now I'll also discuss like lag in writing with the voice. Okay, fine. See, this is when it comes to capnography, I want you to remember a few important capnography waveforms. Spontaneous ventilation, what is shark fin appearance? So this is a controlled ventilation where you see normally where you see the square shaped waveforms. When it's spontaneous ventilation, you see the inverted U-shaped appearance. Then shark fin appearance. From the side, if it looks like a shark fin, it indicates obstructive airway diseases like asthma and COPD. Okay, this is a signature capnograph of bronchospasm, or you may see this in kinking of any endotracheal tube or circuit. Then cardiogenic oscillations are seen in children are in thin chest wall, not very important clinically, but this is important. Curare cleft. In phase 3, if you see this dip, this is called as curare cleft. This indicates spontaneous breathing under controlled ventilation. If this curare cleft occurs in the middle of the surgery, give the muscle relaxant to increase the effect. And if it is the end of the surgery, you administer the reversal agent. So these are few capnography waveforms. Then suddenly, if you see a flat line, the flat line capnograph, suddenly if it becomes flat like this is seen in conditions of cardiac arrest, a circuit gets disconnected, accidentally the patient gets extubated, esophageal intubation. Then when you see the compressions, the EtCO2 waveform touching less than 10 and suddenly increases to 40, that indicates ongoing CPR and return of spontaneous circulation. When you see the slow increase in EtCO2, that is hypoventilation. Other way around, slow decrease is seen in hyperventilation. If you see the rapid increase, it is seen in malignant hypothermia as discussed. Rapid decrease is seen in pulmonary embolism, let it be air or fat, whatever. Then in CO2 rebreathing, usually the waveform doesn't touch the baseline. Sometimes it may slowly increase. Okay. Then in single lung ventilation, this is not very important where you see the notched appearance. So this is about the capnography waveforms, which should be on your tips. So capnography, so there are 1 inspiratory and 3 expiratory forms, and in controlled ventilation, you see the square-shaped waveforms, spontaneous ventilation, normal, you will be the U-shaped waveforms, inverted U, and in shark fin appearance, which is signature capnograph bronchospasm seen in obstructive airway diseases like asthma, COPD, and kinking of endotracheal tuba circuit. Cardiogenic oscillations usually seen in children or with thin chest wall. Curare cleft indicates spontaneous breathing under controlled ventilation. Curare cleft occurs in the middle of the surgery. You administer muscle relaxant at the end, reversal agent. Then flatline capnogram is seen in cardiac arrest, circuit disconnection, accidental extubation, and circuit disconnection. Return of spontaneous circulation when there will be sudden increase. Slow increase EtCO2 is seen in hypoventilation, slow decrease hyperventilation, rapid increase malignant hypothermia, rapid decrease pulmonary embolism air fat, CO2 debreathing waveform doesn't touch the baseline. This should be any of our tips. One question from capnography is almost always guaranteed, let it be MRB or NEET-PG or INSET. As simple as that. If you remember this waveforms, there's no way you can get the question wrong. You will always get the question right. Okay. Then coming to the next question. Pretty straightforward question. Central venous cannulation can be done through the following veins except femoral vein, subclavian vein, internal jugular vein, popliteal vein. Very good. Almost a common sense question. The answer is popliteal vein. What is now tell me which is the most common, if the question is asked, what is the through which vein we do the most commonly central venous cannulation? Fantastic. IJV is the most common. Mainly right IJV we do that. Okay, and subclavian also you do that in very difficult situations. You can go for femoral vein also. So this is the central venous catheter. It helps measuring CVP. The technique of insertion we call as Seldinger technique. Most common size used in adults is 7 French. Normal CVP is 1 to 5 milligrams mercury, and most common site is right IJV. Why do we use this central venous? To monitor the fluid status, to give TPN, total parenteral infusion, for repeated sampling, CVP monitoring, infusing inotropes, transvenous spacing. What is the most common complication that can occur? Pneumothorax. Okay, particularly when we are doing with the subclavian, like it is more common, and sometimes cardiac tamponade and thrombosis can also occur. Okay, and when you are doing through the IJV, if you hit a carotid artery, there might be prolonged bleeding. So all these things has to be careful. Then another important question again related to CPR. All of the following are correct about CPR quality except push at 60 to 80 per minute, push at least 5 centimeters, minimize interruptions in compressions, push at 100 to 120 per minute. Very good. So push at 60 to 80 per minute is wrong. At least 5 centimeters. It is 5 to 6 centimeters we usually do. Minimize interruptions in the compressions. Push at 100 to 120 per minute. So push hard, that is 5 to 6 centimeters. Push fast, 100 to 120 per minute. Minimize interruptions in the compressions. Avoid hyperventilation. This is again another important point. Avoid hyperventilation. So see here, what is in various age groups, what are the differences? Witnessed collapse and unwitnessed collapse. What is a witnessed collapse? If the patient collapses in front of you, what is the first thing you have to do in adults? Activate emergency response system and do the CPR. Same with children and infants. If you ask what is the first step in the CPR, it's always verifying the scene safety. Please remember. Then in unwitnessed collapse, what do? You activate after verifying, this is all after verifying the scene safety. In unwitnessed collapse, you don't know the patient is lying there since how much time. In those conditions, you activate the emergency response system and do the CPR, same in adults. But in children, because the respiratory arrest is more, like you first give CPR 1 cycle, then activate emergency response system and then do the CPR. This is what you remember. Then if you are only one rescuer, you are going alone, what is the compression ventilation ratio? If you are one rescuer, 30:2 in all adults, children, infants. But if 2 of you are there, in adults it is 30:2, but remember in children it is, and infants it is 15:2. Then what is the ventilation rate? The advanced airway is there. How many times you can do? In adults it is 10 breaths per minute. In children and infants it is 20 to 30. Please remember, very, very, very important. This was a question immediately which was asked in 2020 INSET. Once the guidelines came and within few days they asked about this. Then chest compression rate, 100 to 120 per minute is common. Chest compression depth, 5 to 6 centimeters in adults, around 5 centimeters, that's in children, and around 4 for infants. Hand placement, lower 1/3 of sternum in adults and children. Here at the level of nipple encircling. This has been enforced in 2025 guidelines. The tooth thumb thing, they are discouraging that. Minimizing interruptions is common for everything. Okay. Then the strength of adrenaline used in infiltration anesthesia. Again, this was a question which was asked in MRB, NEET-PG, and ANAESTHESIA also. Pick the closest one. Yes, very good. All of you get right. 1 in 2 lakh to 1 in 80,000. So in one of the examinations, suppose if this is the options given, 1:100,000, 10,000, 1:1 lakh. If these are the options given, so what will be the best one which you pick up in this? Fantastic. So this should be the one which picked up. So among this, always the best is for adrenaline, it is 1:2 lakh. Okay, that is the best one. If the option, we have to always remember these examinations are the best answer which we have to do that, not just the right one. Okay, so by addition of this vasoconstriction along with local anesthetic adrenaline, it decreases the local blood flow, it decreases the systemic absorption, and increases the duration of action. So adrenaline is usually in 1:2 lakh ratio, phenylephrine in 1:20,000 ratio. And remember, local anesthetics with vasoconstrictor is contraindicated in all the endarteries. Like you can't give it in finger block, penile block, ear lobules. So clear, guys? Clear till now? Now, just because we are discussing let's also discuss few important points about CPR guidelines. What are the changes of 2025? We are potentially expecting a question from this because they came as recently as in the month of October, and there are high chances, if at all, they want to test upon how updated are you. So we'll discuss few points about that. Will share you this document also with you. So please be assured. So these are only the 2025 key changes and highlights. So here, the strong emphasis is given on equity, ethics, post-arrest recovery across all the sections. So what does it do? In ethics, for ethics alone, there is a separate chapter. This will also be important for your further NEET-PG and INCT exams too. And 4 ethical principles: beneficence, do good; non-maleficence, do no harm; autonomy, respect choices. When they say like don't resist it, you have to respect them; justice, fairness. This has been added, these 4 points. And strong focus on eliminating inequalities in social determinants, not an important point. So institutional ethics committee recommended to resolve conflicts. So we will send you this document to you, please be assured. Then this is very important. Family presence during CPR. Usually when CPR is being done, like we ask them, you go wait outside, you can't see this. No, they recommended this is like family presence is during CPR is supported wherever possible. They don't clearly mention where possible and all. So this is one important thing. Then systems of care. So earlier there used to be OHCA, out of hospital cardiac arrest, IHCA, in hospital cardiac arrest, adult pediatrics. There are like lot of things. Now they have a unified thing. Unified chain of survival is given. And in this, the 6th component, recovery, is there. Please remember recovery. Then for treatment of opioid antagonists, naloxone, the public access should be there for naloxone, and also the AEDs, automated external defibrillators. So they emphasized on this. Then debriefing, both immediate and delayed sessions recommended post CPR. So once you have done the CPR, whether it's successful or not successful, we have to do the debriefing. So immediately what is right, what is wrong, and also in delayed, like after few hours, then again analyzing what went right, what went wrong. And also debriefing is not only for technique effectiveness, but also for psychological technique effectiveness and psychological. Okay. And on-scene resuscitation preferred before transport to OHCA. Before on-scene resuscitation is encouraged, and always ensure the CPR quality is maintained. And eCPR, just remember this word. eCPR is extracorporeal CPR, like an ECMO. You regionalize extracorporeal systems with clear patient selection criteria. If they fit in, we can use it. And in the recent unfortunate event which occurred to one of the CTVS surgeon, he was an alumnus of PJ Chandigarh, like who had a cardiac arrest at the age of 35 years and who straight away drove to one of the medical college and he's having an MI and do that. During that time, all the efforts were done, including the extracorporeal CPR was done for him and continuing that ECMO. So extracorporeal CPR is going to be one of the common things which is more and more centers are procuring that and using it. So structured post-resuscitation recovery programs are advised for long-term outcomes. Then neonates. When compared between early and delayed cord clamping, deferred cord clamping more than 60 seconds, has to keep for both better iron status and survival. Card milking is reasonable for non-vigorous infants more than 35 weeks. You should do the card milking. And initial ventilation, if you want to, if at all situation arises, 20 to 30 centimeters of water pressure at 30 to 60 breaths per minute. And you can use LMAs and video laryngoscope is used approved alternatives to intubation. And pulse oximeter you have to keep in units as soon as possible. And preterm oxygen initially start with 30%, and if it's not improving, only then go to 100%. Don't start with 100%. And chest compression, again, lower third of sternum, change compressor every 2 to 5 minutes. Then pediatric basic life support, when you're doing it, CPR pause should be less than 10 seconds. Compression technique. So it will be the heel of the hand or two-thumb encircling hands. But remember, the two-finger technique has been removed. Please remember. So heel of one hand or two-thumb encircling hands. Two-finger technique where you're doing all the sternum has been removed. Then, if there is a severe foreign body airway obstruction, so what you have to do? This is important. In children, 5 back blows and 5 abdominal thrusts. Alternate back blow, abdominal thrust, back blow, abdominal thrust. That is in children. Whereas in infants, 5 back blows, 5 plus 5 chest thrusts, alternate. So in children, back blow and abdominal thrusts, and infants, back blow plus chest thrusts. This is again an important thing. Then what are the changes in the BLS, basic life support? So head tilt, chin lift we can do if jaw thrust fails in trauma. If you are not able to do the jaw thrust in trauma, you can do the head tilt and chin lift. Ventilation, 1 breath every 6 seconds with visible chest rise. Compression ventilation ratio 30:2 maintained. Mechanical CPR is not routine use, only manual CPR unsafe. What does it mean? This is something called mechanical CPRs which become popular. Whenever a patient got cardiac arrest, you brought one a device where it's like a robo sort of thing. Robo in the sense like it's automatic. What you do is you have to just attach that paddles and you set the rate. It keeps doing the CPR, but that effectiveness is not proper. Then in defibrillation pads, adjust bra instead of the removal and improves equity in women. In obese patient, the standard CPR technique applies. In adults, if there is a severe foreign body airway obstruction, again 5 back blows and 5 abdominal thrusts in alternate cycles. What are the changes in pulse? Epinephrine as early as possible, less than 3 minutes for non-shockable rhythms. ETCO2 more than 20 mmHg should be the target, but don't use it for a sole termination criteria. There are more the other things, but it should not be the only thing. And whenever you are doing the monitoring the blood pressure after resuscitation, the diastolic blood pressure targets in infants should be more than 25 and in children more than 30. SVT, supraventricular tachycardia, which is unresponsive to adenosine. If you are given 6 mg and then 12 mg, if still is not responsive, you can use IV procainamide, amiodarone, or sotalol options. Okay. Then post-cardiac arrest, patient has a cardiac arrest, but you resuscitated him. In those conditions, ensure that you maintain blood pressure more than 10th percentile of that age. And remember, up to 72 hours, you have to use